A very good afternoon to everyone. I'm Dr. Shaheen Sheikh. I'm the microbiologist from SRCC Children's Hospital. On behalf of Society of Clinical Microbiologists, I welcome all speakers, participants, and experts to an exciting academic session with practical take-home messages. But before that, I would like to introduce the Society of Clinical Microbiologists. In 2014, a few of us clinical microbiologists in the city of Mumbai felt the need to form a group to discuss critical issues related to day-to-day activities related to microbiology. And this eventually gave rise to the Society of Clinical Microbiologists, a registered body. We've got around 80 plus microbiologists in our group currently. They're all from, most of them are from Mumbai, but some of them are across the country, and a few international members from Southeast Asia. We've got a pan-India presence. So far, we've conducted more than 35 CMEs. Dr. Shweta Shah, an eminent microbiologist from Kokilaben Dhirubhai Ambani Hospital, created the idea of bucktails, which involves interesting case presentations. This has been happening since July 2021. It happens once every 3 months. I hand over to Dr. Pooja Thakkar. Dr. Pooja Thakkar is a microbiologist working along with Dr. Shweta Shah at Kokilaben Dhirubhai Ambani Hospital, and she will be moderating the session. Over to Pooja.
A very good afternoon to everyone. Warm welcome to our experts, speakers, and my friend colleagues in the audience. Can I request Dr. Darshan to share the screen for introduction of our speakers?
Yes, ma'am. Can you see my screen, ma'am? Hello.
Darshan, we are looking at the whole desktop of yours, not the slide.
1 second, ma'am. 1 second. I will do this. Okay.
Once again, thank you to all the audience for logging in right now on a Saturday afternoon. Let me assure you it will be a very fruitful session. For all those who just logged in, we are going to have an interactive learning session, case-based learning session on prosthetic joint infection.
Ma'am, is it visible now?
Yes. Thank you, Dr. Darshan.
Thank you.
So it gives me immense pleasure to introduce our first expert for today's session, Dr. Vidyulata Khoparkar. She's the consultant infectious disease at Wokhar Hospital and HCG Hospital, Mumbai. She has been previously associated with Apollo Hospital, Ahmedabad, Nanavati Hospital, Mumbai, PD Hinduja Hospital, Khar. She's a member of the Infectious Disease Society of India, and she has also been on COVID response advisory panel. She has many original publications, book chapters, lectures, and scientific presentations to her credit. Good afternoon, Dr. Vidyulata, and a very warm welcome. Our next expert for today, it's my privilege to introduce Dr. Alankar Ramtake. He's the consultant orthopedic surgeon at Arthritis and Joint Replacement Clinic, Wokhar Hospital, Nagpur. He has participated in over 3,500 primary joint replacement and many complex revision surgeries over the last 2 decades. He was awarded the best lecturer at Grant Medical College and Sir J.J. Group of Hospitals. He was presented with the Outstanding Young Achiever Award by Academy of Medical Sciences at Nagpur for the year 2015-16. He has been trained at New York, US under the prestigious Ranawat Joint Replacement Fellowship and also has received fellowship training at international centers of repute at Seoul and Melbourne. He has a special interest in joint preservation surgeries, especially in the young. He has served as a member of editorial board of Indian Journal of Orthopedic and Journal of Orthopedic Case Reports, and also a reviewer for key international journals in the field of knee and hip surgery. He has many publications in reputed international academic journals in field of joint replacement surgery. A very warm welcome, sir. Our next expert is Dr. Rupa Vishwanathan. She's the clinical microbiologist and director, Polylife Diagnostics, and also joint director of Polylife Brain and Spine LLP, Mumbai. She had completed MD in microbiology from Sion and worked as a lecturer for 3 years. She then headed microbiology department at Bombay Hospital for 4 years. Later, she has worked as a clinical microbiologist and infection control officer for Ministry of Health, Brunei. Currently, she is an infection control consultant for many hospitals and consultant at Unilever companies for clinical trials for their hygiene products. She's also a member of the Ethics Committee and Biosafety Committee for various institutions. Dr. Vishwanathan has many publications to her credit in peer-reviewed national and international journals. She's a keen academic and is also a founder member of Society of Clinical Microbiologists. And it's indeed a proud moment for us all in the microbiology fraternity. For 21-22, she's been the recipient of Women Empowerment Entrepreneur Award by ET Now. Good afternoon, ma'am, and welcome to today's session. So before we begin, general flow and agenda for our audience, faculty, and speakers. So today, through case-based learning, we would like to know what exactly is prosthetic joint infections, what are the case definitions, is there any consensus between IDSA, orthopedic surgery, or is there any difference in the case definition? From the microbiology audience perspective, we would like to know what samples, how many samples, how to process, are there any standard protocols for the same, and are all labs following it, and is there a need for harmonization from the diagnostic perspective? Treatment guidelines, medical as well as surgical options available for prosthetic joint infections, and day-to-day challenges faced and the role of multidisciplinary team in treating prosthetic joint infections. Next, please. So for our audience, I would just like to say that we'll be introducing 2 cases we have for today, and there'll be 2 to 3 speakers per case presentation. As we mentioned, it's a joint team effort, so even the case presentation will be a team effort. And once the speakers have presented their case, first we'll be taking comments and questions from our experts. Then we'll be taking questions from the audience. So if you have any questions, I request you all to post your questions in the chat box. And if you have any specific question towards a particular speaker or you want an insight from our expert panel, then please mention their name. We'll direct the questions directly to them. And also, at the end of the session, I'll be again reminding, but just if we would really value your feedback for the session, and you'll be able to collect your certificate of participation once you've given the feedback for the session. Next, please. So moving on to our first case is on prosthetic implant infection due to MRSA. We have 2 speakers. First, I would like to introduce Dr. Shantanam N. He's the senior resident doing DM in infectious disease at AIIMS Jodhpur. He'll be joined by the next speaker, Dr. Akshata R. She's also a senior resident doing DM infectious disease specialist from AIIMS Jodhpur. Over to you, Dr. Akshata and Dr. Shantanam.
Thank you.
Thank you, ma'am. Thank you for kind introduction. Straight away, I'm starting with the case.
Sure.
82 years male from Jodhpur. He is alcoholic, chronic opium addict. He is doing railway officer for past 30 years. 60 years of age, he is retired. He came with chief complaining of fever for 3 weeks, swelling and pain in the left upper thigh for 2 weeks, and altered sensorium for 4 days. Patient history elaborations. Patient had fever for 3 weeks. It is continuous high-grade type of fever. It's no diurnal variation morning or night. It's not associated with chills and dry hair. It's not relieved by any medication like paracetamol or whatever he took. It's not relieved. He had swelling in the left upper part of the thigh for 2 weeks. It is acute in onset. It's not localized to any site. It will be diffuse. Swelling started comparatively. It started increasing. It's not relieving by any medication, and he took some treatment outside also. 2-3 days. It's not improving. He had pain for same time 2 weeks. It's not. He limited movements in all direction because of pain. The same thing also, he took medication, it's not relieved. He had altered, after that, he had altered sensorium for 4 days. No headache, and no vomiting, no abdominal pain. He had altered sensorium. Slowly he started speaking is altered, and then he became a little bit agitated. He had urinary retention for past 2 days. This much history only he had. And then we ask for, usually we take good history. We need to ask for past history also. He had a history of 1 year back, RTA. His diagnosis left endotrachonic fracture and treated with close reduction and internal fixation and nailing in proximal femur. Proximal femur is done at the time. He is stable, no complication at the time of surgery. But he had urinary retention multiple times. Once catheter removal, again he developed urinary retention, and he had multiple catheterization outside also. Quick summary patients. Elderly male from Rajasthan. He had 3-week history of fever, swelling and pain in the left upper thigh for past 2 weeks, and altered sensorium and urinary retention for 2 days. Past history of RTA, case of endotrachonic fracture in left proximal femur, and then at the time is nailing done. At this point, what are differential diagnosis you will suspect? This patient have persistent fever. That point will diagnose as sepsis, whether possible of skin and skin structure infections. He had altered sensorium. Meningoencephalitis one of the possibility. Still we can't rule out. Prosthetic joint infection. These are all DD, we kept it. And then we started empirically antibiotic, Piptas 4.5 gram, Q severely. At the time emergency, they started. And the examination, patient is irritable, moderately filled, moderate nourish, and fever. The temperature is 1 or 2 degrees Celsius, 1 or 2 degree Fahrenheit. Sorry, it's no pallor, no jaundice, no clubbing, no pedal edema. Vitals, pulse, BP, respiratory rate, everything normal. SpO2 97% on room air. Fever, little bit irritable sensorium he had. Systemic examination, he had CVS, RS, abdomen, everything normal. No abdominal pain, no renal angle tenderness, everything. Central nervous system examination, GCS at the point 12 he had. No signs of meningitis, neck rigidity, hernic sign, foot syncage signs. Plantar examination shows bilateral plantar extensor. Fundus we did, fundus is normal. Local examinations, left upper part of the thigh, show signs of inflammation in the form of redness, pain, swelling he had. And then he had restricted movement in all directions. Left upper part of the thigh. We came differential diagnosis restricted to whether possibility of prosthetic joint infection and the skin and skin structure infection, it will leading to cause sepsis. And then we sent for basic investigation, CBC, inflammatory markers, KFT, LFT, and X-ray, blood culture at the point we sent before starting antibiotic we sent. Preliminary investigation shows elevated total count and elevated inflammatory marker like ESR, CRP, Procal, everything elevated. Procal 9 at the point. KFT 1.3, creatinine, LFT albumin is altered 2.3. Otherwise, no viral marker is non-reactive. And urine routine shows only 2 to 3 parcels. It's not significant. This is patient X-ray at emergency. CCT shows bilateral lacunar infarct in capsular ganglionic regions. Is no leptomeningeal enhancement. CSF shows no evidence of meningitis, and even expert and other gram stain everything sent, it come negative. We sent at the point of time blood culture blood culture report came. Its growth as gram positive cocci, time of positivity 7 hours one thing, another one 18 hours. Diagnosed as Staphylococcus aureus. The sensitivity pattern is it's resistant to penicillin, cefoxitin, erythromycin, and clindamycin, intermediate to levofloxacin. And other things are sensitive like cotrimoxazole, Genta, Vanco, Daptomycin, linezolid, and other things are sensitive. It's confirmed as MRSA. What to do next? This I will hand out to my co-PG. Thank you.
So in a situation, so you can see here we have isolated Staphylococcus aureus in the blood. So what would you like to do next? So whenever you see Staphylococcus aureus bacteremia, you can start empirically before the susceptibility is available, vancomycin or with cefazolin. And very important thing is you will always have to look for the source of the infection. It can be skin, joint, lung, IV lines, endocarditis, or it can be any other. You should also look for metastatic complication. And you'll also have to do the repeat blood culture every 48 hours until you document the clearance. And 2D echo is required. At least the transthoracic echo should be performed. Then imaging must be done to assess the metastatic complication as well as to assess the source. And the most important thing is you always have to look for the source, and adequate source control has to be done. And ID consultation or the infectious diseases consultation is imperative. It has been shown that it will improve the outcome of Staphylococcus bacteremia. And based on the culture report, whether you have isolated MRSA or MSSA, you can start the stop the other antibiotics. So if it is MRSA, you will continue Vanco or Dapto. MSSA, cefazolin is the drug of choice. So in our patient, Piptaz, the piperacillin tazobactam, which was stopped, and the patient was started on in view of the AKI with the eGFR of 63. We started the patient on teicoplanin, and teicoplanin it was given as 12 mg per kg dose. 5 doses loading dose followed Q12 hourly, followed by 12 mg per kg Q24 hourly. So to pursue the source control, as we had seen, there was a significant swelling in the left upper thigh. So ultrasound was performed, which revealed diffuse subcutaneous thickening, likely cellulitis, and there was also a well-defined collection measuring 3 into 13 into 11 centimeter with around 230 cc of collection, which could be mostly abscess. And this collection was just superficial to the trochanter and the shaft of the left femur. Transthoracic echo was done, which revealed with an ejection fraction of 60%, and there was no vegetation or clot. The abscess was drained, and the abscess was sent for the culture. And behold, we have the same organism, Staphylococcus aureus, MRSA, with the same sensitivity. So this brings us to the question, when should you suspect prosthetic infection? So PGIs, there are increasing number of patients who are undergoing prosthetic surgeries and prosthetic joint replacement. So we should always have a suspicion. So when should you suspect? When a patient is having one or more symptoms, such as unexplained pain or fever, redness, swelling, scar formation, movement restriction, and these symptoms are not very specific. And if the patient is having such symptoms, we'll have to do other investigations to further provide evidence for this PGI. And so this is in cases of acute presentation. Some patients will have indolent or they will have a chronic presentation, or the late onset prosthetic infections will have insidious presentation, which can present as generalized malaise or sepsis of unknown origin. And in case you're seeing any sinus tract, this is very pathognomic, but it is not necessary that all your patients will be presenting to you with this. So again, it can be classified into early, delayed, or late PGI based on the duration of the onset. If it is less than 3 months after the joint replacement, it is deemed defined as early or acute PGI. And usually the likely source of infection is perioperative flora. So you will be seeing group A Streptococcus, Staphylococcus aureus, and it can also be polymicrobial. Delayed onset or the chronic PGI is the time of onset is between 3 to 12 months. Again, the source of infection or the likely organism can be coagulase negative Staphylococcus. QT bacterium is one of the important anaerobic bacteria which can cause and enterococci. Late onset is more than 12 months, and in this situation, it can be either through the perioperative or the hematogenous dissemination leading to the later PGI. It can be the common organisms include Staphylococcus aureus, gram-negative bacilli, cons, NTM. Even you will need to suspect fungal in such a situation. So there is a definition of the PGI which was revised in 2020 by the EBJIS. So they have 3 different criteria, that is infection unlikely, likely, as well as infection confirmed. It is based on the clinical, laboratory, as well as the radiological findings. So if none of these, there is no finding of clinical or the lab or the radiological, the infection is, the PGI is supposed to be unlikely. If there are 2 positive findings, either there is clinical and laboratory correlation, such as clinical correlation such as early radiographic loosening, wound healing problem, recent fever or bacteremia, purulence around the prosthesis, CRP more than 10, and laboratory features of this either the synovial fluid aspirate or any aspirate taken around the implant showing leukocyte count of more than 1500, which is predominantly PMN type, or seeing a positive culture of a pathogenic organism such as Staphylococcus aureus, and presence of more than 5 neutrophils in the single high power field in histology. Radiology, it can be demonstrated by positive WBC scintigraphy. So in our patient, we had the factors A and B which were positive. So the patient had recent fever or bacteremia with purulence around the prosthesis, and CRP was very much elevated. It was in the range of 400s. There is a positive blood culture, and as well as the pus culture showing Staphylococcus aureus. So periprosthetic infection was likely. Infection is confirmed if there is if in clinically you are seeing the sinus tract. As I mentioned, it is very pathognomic of a PGI or any bone and joint infection. Then in laboratory, if there is leukocyte more than 3000, PMN more than 80%, and with a positive alpha defensins. So, Staphylococcus aureus bacteremia can be classified as complicated as well as uncomplicated bacteremia. So why do we need to know this difference? Because the duration of the management or the type of management will differ based on it. So any patient who is having osteomyelitis or infective endocarditis is deemed to be complicated bacteremia. And also it includes if the patient is satisfying any of the one of these features, such as presence of endovascular foreign material like prosthetic valves, cardiac device, vascular grafts, persistent bacteremia after more than 72 hours, lack of clinical response in terms of deference within 72 hours, and if the foci is identified but not removed, and presence of metastatic phenomena and evidence of endocarditis are called as or defined as complicated bacteremia. In this patient, we need to give longer duration of therapy, 4 to 6 weeks, depending upon the patient's response. And it is necessary that you give parenteral therapy or the IV therapy in these patients. And if the patient is not having any of these features, if you can, but there is still high possibility of IV you're suspecting, you'll have to go for further investigations like transesophageal echo or the PET-CT. And in that TE or PET-CT, if it is coming positive, again, you will have to give for a longer duration. In case it is absent or in case of uncomplicated bacteremia, it can be treated with 2 to 4 weeks of the antibiotics. So in this patient, repeat cultures, blood cultures were sent every 48 hours. So the patient blood culture was sent on 13th as well as 16th, which showed it was sterile. But the patient was still febrile. The patient was having a spike of fever every day almost. So the patient was still pursued, and on 20th, it showed blood culture again positive with MRSA, with a vancomycin MIC given by the Vitek as MIC1. And we also asked for specifically to perform vancomycin MIC by the E-strip, which showed the MIC of 1.5. So here you can see that there is some discrepancy. So in between, you're seeing 13th and 16th, the cultures were negative. So how do you explain this blood culture negative in between? And this is a known phenomena. This is called the skip phenomena in Staphylococcus aureus bacteremia. And this is defined as when, despite appropriate antibiotics, Staph aureus might exhibit fluctuating blood culture positivity, and this is termed as skip phenomena. And this has its implication in the clinical management because they are usually associated with longer duration of bacteremia, high-grade bacteremia, and complicated bacteremia. And that is why it is necessary that you send serial blood cultures to document the bacterial clearance. And as I mentioned, the vancomycin MIC was found to be 1.5. So what is the implication or the clinical implication of vancomycin having a MIC of 1.5? So as we all know, the vancomycin breakpoints, it still between up to 2, it is termed as sensitive. So, and between 4 to 8, it is termed as intermediate. So this will be reported as susceptible only, and this is important because there is a phenomenon of MIC creep, that is reduced susceptibility of vancomycin with it will be reported as susceptible, but there will be reduced susceptibility to the vancomycin, and vancomycin reduced susceptibility also will imply reduced susceptibility to teicoplanin, and that is why it is necessary that you do a MIC susceptibility testing method either by E-strip or any broad microdilution, and not rely just on disc diffusion or the automated methods. So this brings us, how are we going to manage? The patient is having persistent MRSA bacteremia even after 72 hours, even after giving adequate dose of the therapy. So first and foremost, you should always look for a source control. In our patient, we did a repeat USG, which showed there is no presence of the abscess as such. Then IDC guidelines recommend that you change the therapy rather than adding an additional agent. So you can shift to any high dose daptomycin if they is susceptible. And second agent you can which can be gentamicin, rifampicin, linezolid, or cotrimoxazole, depending upon the susceptibility. So these are the suggested combinations which you can use in persistent MRSA bacteremia, either high dose daptomycin plus rifampicin. This is a very good combination, especially in patients who are having infective endocarditis, foreign body associated infection, or prosthetic device associated, because it has an additional, apart from the synergy, it has an additional benefit due to the ability of the rifampicin to act on the biofilms. Vancomycin plus beta-lactam can be given. So what is the beta? So the beta-lactam will cause the cell wall thinning, and so this vancomycin binding will increase to the target site. And this beta-lactam can be cefazolin, cloxacillin, etc. And other beta-lactam, ceftaroline also can be added. But this, apart from the synergism, it has an additional anti-MRSA effect as well. Daptomycin with beta-lactam can be given. So the beta-lactam will reduce the cell surface charge and enhance the daptomycin binding. Again, the beta-lactam can also be ceftaroline, so which also has an anti-MRSA effect. So if for vancomycin or daptomycin sparing agent, one of the combination which can be used is fosfomycin plus imipenem. This fosfomycin will down-regulate the penicillin binding too, so that imipenem can become effective in situation. So we wanted to start the patient on daptomycin, but due to the cost and the availability issue, the patient was given teicoplanin with injection cefazolin due to the non-availability of daptomycin as well as ceftaroline. So the patient still had fever. So we were looking at, because it was suspected to be prostatic joint infection likely. So we were looking for the management of the prostatic joint. So surgical debridement and prolonged high-dose antibiotic therapy is the mainstay of management of prostatic infection. And if the patient is stable, there is no requirement of empiric antibiotics. But in case if it is coming, cultures have it is proven or infection likely, you can start the antibiotic. And surgical management basically is of two types. Either you can retain the prosthesis or you can remove and re-implant the prosthesis. And the retention of prosthesis, there are fixed indication. If the patient has well-fixed prosthesis without a sinus tract, and if it is occurring within 30 days of prosthesis implantation and less than 3 weeks after the onset of the infectious symptom, so we can do something. The term is there, that is debridement, antibiotics, and implant retention of the prosthesis. And removal and reimplantation approach, again, it can be of various approach. There is 1-stage approach, 2-stage, 3-stage, and last thing is what you can do is permanent resection with arthroplasty. So these are the various surgeries. So retention of the fixed prosthesis, and the other thing is 1-stage exchange, 2-stage exchange, and 2-stage long interval and short interval, and 3-stage exchange. So in this, what is differing is the duration of antibiotic, what type of antibiotic you will be giving. So 1-stage exchange involves, so I will do one surgery, you will remove the implant and give IV antibiotic for 2 weeks, and after which you can do the reimplantation. In 2-stage exchange, there will be reimplantation after the 2 weeks, followed by 9 weeks of an oral antibiotic with bioavailability. And in 3-stage exchange, you will do the explantation with a then exchange with a spatial, then implantation at the interval of 3 weeks, and followed by 5 weeks overall of 5 weeks of the post-operative antibiotics with an antibiofilm effect. So the overall duration of antibiotics is going to be 12 weeks. So the patient now is having PGI with Staphylococcus aureus. So how are you going to manage a case with PGI with Staph aureus? If it is early onset, as I mentioned, you can try DARE. So DARE, along with the parenteral therapy of vancomycin or teicoplanin with rifampicin, followed by rifampicin plus fluoroquinolone or cotrimoxazole, etc. If it is late onset, prompt device removal is advised, and long-term oral suppressive antibiotics if the device is not removed. So the duration of therapy for late onset will be 6 weeks if it is removed. If it is not removed, 6 weeks followed by 3 months for hip replacement and 6 months for the knee replacement. So in our patient, because of the age and his comorbidities, he was 82 years. So the patient underwent removal of the prosthesis with arthrodesis on 1st of August. And the patient received full IV course of teicoplanin plus cefazolin. Subsequent repeat blood cultures on 3 sets in 3 different occasions were sterile. And the patient was afebrile. Intraoperative abscess culture again was sent, which showed abscess, and the implant was sent for the culture, which showed it was sterile, and inflammatory markers had settled. Thank you. So that was all about our case.
Thank you, Dr. Shantanam and Dr. Akshata, for the detailed case presentation and, crystal clear review of literature. Thank you very much. And may I now request the experts, Dr. Vidyulata, your comments or any questions for the presenters?
Yes, what was the vancomycin MIC to begin with? The first cultures on the blood culture and the from the abscess culture, that we don't know the MIC. Secondly, was rifampicin, why was it not? I mean, was it considered? Because it could have been a good add-on in case of prosthesis in situ. And did the patient have a central line for administration of antibiotics? Because that can also be one of the one of the reasons why the cultures can later on become positive. Plus it can, maybe an echo could have been repeated in that case if there was a persistent MRSA bacterium.
So, ma'am, answering the first question. So the initial, they had not provided the vancomycin MIC. The patient, so it was not reported. So when we intervene and when we were signing, we specifically asked for the vancomycin MIC. So that is when it was reported. Answering the second question, what was
on a Vitek you would get it, no?
No, the second
on the
one
Vitek,
was Vitek.
it was an automated system, no?
Yes, ma'am.
Yeah,
Achha,
second
okay.
one was Vitek. The first one was the disc diffusion based method which they had reported. Repeat echo was done. Again, there was no vegetation which was seen. Even T was planned, but T was not possible. Transthoracic was repeated. It was no vegetations were
Was
found.
this person an intravenous drug abuser? Because
No,
he was not an IV drug, only opium. Okay.
So
because
not
the
a
fever is preceding the joint involvement, so probably the source, I mean, and it is more than 1 year of more than 1 year was over, na, before the prior surgery. So probably it is exogenous. I mean, it's a delayed. What we would say, it's a late. So it's a hematogenous spread of Staph aureus involving the joint, unless that the patient at the beginning, did the patient have a history of PGI immediately post-op?
No, ma'am. He did post-op course was clear.
Post surgery.
So, post-surgery there was no history of fever, no complaints. So we are not sure whether it was staph from hematogenous seeding into the prosthesis or prosthetic seeding into the blood.
The fever is preceding. In that case, if there is no clear history, because see, even if the immediate pre-op the patient had a Staph aureus infection and for some reason debridement retention had worked at that time. Yeah, am I audible?
Yes, just for a brief intro, I couldn't hear.
Okay, so in those cases, even after many years, we do see this biofilm disruption after a minimal trauma also, and then that can be, the old infection kind of like it has recurred. It's like this, but you are saying that he did not have any history of such an infection, and here the source wasn't very clear at all. Okay. So because there are certain you said that TE was not possible anyway. There was because TE is mandatory in Staph aureus bacteremia if the patient has an underlying valvular condition, or a patient has a prosthetic valve, there is any valve condition, or he is an IV drug abuser. But yours is an opium addict, not an IV drug abuser.
Not IV. Actually,
and why rifampicin was in particularly not used?
Rifampicin, yes, ma'am. Actually, we had discussed in initial time only. We were in talks with ortho for the implant removal. So that was the reason, and also it was not clearing. As actually, rifampicin is recommended after the clearance of the bacteremia. In case of Staphylococcus bacteremia, after at least 3 days or post clearance, because only rifampicin will again lead to the resistance only. So we were planning.
In the planktonic phase, usually it is antagonistic to the drugs which you are using. But here the prosthesis was there and initially it was covered. So whether it after 3 days, after the first cultures were negative. Now you were doing it every time. You were doing it after every 48 hours. You just mentioned. So that is probably, I don't know whether it could have been added because you had quite a lag between your recurrent positive cultures, where probably the source was clearly then the seeding of that prosthesis. And he cleared the bacteremia after that, right? After
yes.
And you did an arthrodesis. There's no
arthrodesis, no other. Because of the age, 82 years. And actually it was more or less bedridden. So that was just for the source control purpose, we had the implant removal.
And that's it. I mean, you said you couldn't procure the other medicines. Otherwise, because choice would be to use a better this thing.
Daptomycin.
Dapto or ceftaroline, but you were not, you're not able to procure it. Fair enough.
We were planning for Dapto plus cefazoline. Actually, Dapto plus ceftaroline is the preferred one. One cost issue and availability is the big this one. So at least Dapto plus cefazoline we were planning.
Dapto plus cefazoline.
Yes.
Again, I would not combine that. I mean, Dapto with in this case, it's a community-acquired MRSA. It is sensitive to your trimethoprim, sulfamethoxazole, and doxycycline or something. That's what it was mentioned. So, I usually combine Dapto with that. I don't use Dapto with cefazoline. Vancomycin plus cefazoline. Definitely, there is literature on that, and you probably used equivalent glycopeptide. It's just that the US does not have teicoplanin, so we have little less literature on teicoplanin plus cefazoline, but the rationale is the same. So I think that you've used ceftaroline now, you've used in your practice or no?
No, ceftaroline we have not. Daptomycin we have used on and off when we could procure. So, but ceftaroline,
availability.
no, it is too costly for the government institute to procure.
Sure. Thank you, Dr. Vidyulata. May I request our next expert, Dr. Alankar, to put in his comments?
Thank you, Dr. Pooja. At the beginning, I would like to thank Dr. Aruna Pujari for inviting me or making me a part of this discussion. I'm like really happy. Usually we talk to orthopedic surgeons and there are so many things that we don't discuss. We discuss mostly, I'm being sarcastic here, we mostly discuss things like plumbers. We don't discuss like scientists, but I think this is a proper scientific forum. And there's one more thing before I start discussing about the case. I'm so happy and impressed that there is so much preparation going on in the background. I had a trial run yesterday. I think this is like really impressive. You guys have done tremendous preparation for this meeting, and I think this is a very good meeting. Congratulations to all of you, all the organizers.
Thank you.
Let me get back to the case, and I will add my perspective as an orthopedic surgeon, because how we do things, there are some surgical or orthopedic insights which only we see, and other faculties, they don't see that. So here comes my perspective, where I think that is there a role of routine MRSA screening, and whether we should screen our patients, it depends from institution to institution. So to the presenters, I would like to know, was there a history of multiple hospital admissions for this gentleman, and did he have any other comorbid illnesses?
Questions. He didn't have multiple hospitalization, but for in view of urine retention, he had a prostatomegaly for which he had repeated catheterization. There was no admission into the hospital.
So I heard this. So this may not be particularly related to this case, this patient. But then when a patient comes to me who says that he has urinary difficulties, I would always do a urine routine and urine culture for this patient. Especially, I don't fix fractures. I do a lot of hip and knee surgeries as a part of my practice. So for these patients, like, we are really careful, and we would do a urine culture. We would also do the USG KU bio. I hope there are some surgeons here. So we will come to know about prostatomegaly. So intraoperatively, we will be careful that if we are not able to negotiate the Foley's catheter for him, we might have a neurosurgeon stand by. And then the second point is, this patient has a history of alcohol and opium addiction. So Dr. Vidyulata Koparkar asked if he was an IV drug abuser. In my practice, if a patient comes to me with a history of alcohol or opium addiction or any kind of substance abuse, it raises red flags, and we are very careful in evaluation of this patient. They are at very high risk of surgical site infections. Was there a history of delayed wound healing for this patient? Okay, there's one more comment. I think the team who managed this patient, they were lucky because you had a localizing sign. Many times these patients, they have an implant and they present with only septicemia and bacteremia and toxic. They are admitted in a toxic situation, but we never know what is happening. And then while we evaluate, and many times these patients are also not conscious. They cannot give you history. So we have to like really struggle to find out where is the cause of infection. You were lucky that there was localizing signs and you could see that. So that is very good. So we would also ask history in these patients, whether they had history of delayed wound healing and how sutures were removed, where they removed immediately after surgery, or the surgeon took some time and was there soakage of sutures. This raises red flags, and you think about periprosthetic or surgical site infection. And you mentioned about if there is a sinus tract, so it is diagnostic of infection. So there is a slight modification here. Sinus tract communicating with the joint is diagnostic of infection. Okay. And they would definitely ask about history of delayed suture removal and other things. And Madam Dr. Vidyulata, she mentioned that this is 1 year, so this is delayed infection. So I personally follow a classification which is called a Zimmerli classification. It is from the US, where they say that within 3 months is early, 3 months to 24 months is delayed, and beyond 2 years is late infection. So early and delayed infections within 24 hours, the source is exogenous. It is during surgery, and sometimes there can be silent infections where they present, where we come to know that there is purulence only during the time of surgery when you revise it. So this patient most likely had inoculation or infection during the time of surgery, and because he was given antibiotics perioperatively, so because within 2 years, if the infection is there, he presents with infection, and this gentleman presented only with 1 year. So now we will also discuss some orthopedic things. This fracture is not, my lot of respect to the operating team who operated this patient, but this fracture looks like it is not well reduced. And there are signs that this surgery had some struggle. So this is not the best reduction that the surgeon could have done. And this location is known to be a tough location. So maybe they struggled during the surgery, and this patient also looks like he is elderly, he had urinary difficulties and all those things. So I think they struggled during surgery. The duration of surgery might have been more. So I would have liked to see better X-rays. We just showed one X-ray in the presentation, and there you could not see good alignment. So I'm thinking maybe there is a possibility that the surgeons or the surgical team struggled during operation of this patient, and then the surgery could have been delayed. And all these factors are associated with higher risk of infection. There are a few more points. So because you have already taken the implant out in view of age, so implant retention is possible, and implant removal and all these things are possible. But there are two things that we must discuss. So a fracture surgery and its management is different from a joint replacement. When you do a joint replacement surgery, it is irreversible. So after some time, if you do a fracture surgery, you can take the implant away and the patient will continue to work. So even in presence of infection, these fractures, they go on to heal well in a normal course of time. And then once it has healed, it has served its function, and you can take the implant out. Once you take the implant out, the nidus or the source of infection is gone, and these patients do well. But not in a joint replacement situation where this implant is permanent, because it replaces the function of a body which is not functioning. So these implants have to stay there, and the treatment is different. Sometimes you can continue to keep the implant in the body for a fracture where a nail or plate or screws are there. You can continue to keep them. You can do antibiotic suppression, and then these implants come out, and the patient is most of the times healed of or cured of infection. So they are two different situations. For this gentleman, I would have chosen to do antibiotic suppression for him, or maybe use something like a antibiotic impregnated nail and do a nail exchange. Madam Aruna Pujari, she asked me if you can reuse the implants. Generally, as a rule of thumb, we don't reuse the same implant, but sometimes as a maybe intervening procedure, you can use the same nail, antibiotic coat it if you have culture sensitivity, and then put it back again, but which is very rare. And if you continue to keep the implant, there are high chances of infection. And then I spoke about antibiotic coated nails, and yeah. So in this patient, there were two different things that we were dealing with. One is bacteremia and one was local infection. So we have to treat both of them differently. That is my orthopedic perspective. Thank you.
Thank you, sir. Thank you for giving that
Thank you,
insight.
Dr. Alankar. May I now request Dr. Rupa Vishwanathan to give in her comments or questions for the speakers?
So, getting Staphylococcus aureus in a PGI is not a surprise, and MRSA is also quite common. But what still is hitting me is that what could be the, being a microbiologist, first of all, I'm thinking in terms of where the MRSA has come from. And Dr. Vidyulata, Vidyulata had already asked you about whether the patient had IV opium abuser, but he is not an IV opium abuser, right? That's what the answer that you gave. And the second thing was, I was thinking, would MRSA screening, was MRSA screening done subsequently for this patient?
MRSA screening, no.
It was not done. So I was just wondering whether MRSA screening should have been done, because 9 out of 10 times in our experience, we have found that patients who end up with MRSA infection have been already pre-colonized. So that is one thing that we could have, looked for. So that is what is coming into my brain as to why this patient ended up with a MRSA infection. What could be the source of the MRSA? So that is something which is still baffling me. So that's why I was wondering if we could, and also there are multiple, thoughts as far as MRSA screening is concerned. Many think that MRSA screening should not be done on a routine basis, but this particular case really makes me think: should we have been, should we have paid attention to MRSA screening in this particular case? So that's
actually, sir had mentioned. So here the patient seeding could have.
The other members, other experts can have their views.
Like sir mentioned, the seeding could have happened during the time of surgery. So that could have been still the source of the Staphylococcus aureus. Yes.
So all the more reason that I feel that the patient must have been harboring MRSA right from the beginning. So
yes,
this is what I'm
actually
thinking.
recently one study has been released, so where they are mentioning about the screening of MRSA and pre-op for the surgical patients and adding cover for staff based on that. But again, it is a variable perspective. Yes, ma'am. Thank you.
Just a comment here. You said regarding the MRSA screening, the usual policy that is employed is either pre-operative or a patient who was hospitalized in another hospital and is then coming to your hospital.
Yeah.
That is where they have this policy. Generally this patient presented as sepsis. So, and with the possible history that he could have been even into urosepsis. So with this, the MRSA screening upfront would be, usually the hospitals would not have such a policy. Because you just answered, I think, Dr. Alankar, that he did not have repeated hospitalizations. So as a result of that, whether we actually do not use a policy where we screen everybody for MRSA. That's one thing. And second, as we are dwelling on what would be the possible source, did this patient have any skin conditions like psoriasis or eczemas and all those? Because in those patients, community acquired MRSA is often, even as a colonizer, you will get it. And even these people at a very high risk of, this MRSA related bacteremia, as well as then if he has a joint in situ, of course, the joint may be secondarily involved. So he did not have any of this either. So we are still confused, the source. Okay.
So we have a couple of questions from the audience. Before I would like to ask Dr. Aruna Pujari, ma'am, you had raised your hands. Do you have any specific comments?
Yeah, actually, meaning regarding the screening, while it's correct that, you should have a source, I still feel that, MRSA screening should probably cannot be generalized in our country where, overall MRSA infections are very few. It's unlike the West where, MRSA is at the, top of the list of any infections that would happen, including a line-associated infection. In India, we hardly see anything like that, whether it's community or in the hospital setup. So, just pushing everyone to go into screening, whether it's a dialysis patient or whether it is, major orthopedic surgeries or any other for that cardiac surgeries and so on is probably not justifiable. What certainly needs to be done is risk assessment. So I think Dr. Vidyulata talked about IV abuse, and I think this patient did have some kind of an addiction. I think that needs to be given some bit of significance. Second is repeated, even if he was never admitted, I think important is that he had healthcare contact. He came probably into some kind of emergency setting or OPD setting wherein catheter was introduced, and that was another risk factor for him. So maybe this patient could have qualified for whatever screening, but I don't think we should really generalize MRSA screening. If both the experts, all the three experts, have any other meaning opinion other than this, maybe please correct me if I'm wrong.
Madam, that's what I mentioned, that we usually resort to pre-operative or a patient with when he's shifting from one hospital to other, recent hospitalization, if I may put it that way. So usually that has been the policy even in our my institute where I've worked studying.
Yes, Dr. Vidya. Dr. Alankar, you had some comments.
If the patient is high risk and we have all these red flags going on, we can do case-based screening depending on risk.
Yeah. My suggestion is that wherever we are growing MRSA, we might as well, screen the patients and see whether there is any colonization. This is what my take on this is.
I think this is also important, meaning you might not want to do a pre-op screening on everyone, but what Dr. Rupa says also, meaning in fact, we also do. Whenever we find an MRSA somewhere, we go about finding out if the patient is colonized. And probably nostril colonization, while most of us do nostril colonization, screening rather, that may be one of the most common, but there are plenty of other sites. At least 30% of patients you might find actually not colonized in the nostrils, but colonized elsewhere. For example, groin, scalp, and those other areas.
Groins and axilla. Yeah, groins and axilla are very commonly colonized as compared to nasal. And
that
nasal,
could have been an exercise that could have been done. I agree with you. I think this is an important practical point from the microbiology point of view, that we need to, if we grow MRSA, we need to suggest. So it can be, more kind of, targeted versus trying to generalize everything. Thank you.
Yeah.
So before we begin with the questions from the audience, since we were discussing so much about MRSA screening, so what are your comments on screening of the operating team for MRSA?
Pooja, can I take that?
Yes, ma'am.
So there is no no point in screening the in the same OT. Otherwise, there is no point in screening the stuff. I don't think it is a wasteful exercise. I don't think we should be screening all our staff for MRSA screening.
Sure. So we now begin with the questions from the audience. The first question is from Dr. Shilpa from Bangalore. Is there a role of fungal infection in prosthetic implants? Dr. Vidyalata, would you like to answer? How common are fungal infections in prosthetic implants?
We do see that. It's not an unknown phenomenon, especially after COVID. We did see a lot of candida infections in spine and other, in joints. They were even native joint infections. So prosthetic joint infections usually does happen at the time of surgery only. Very rarely, again, secondary candidemias and all. It has a very high likelihood of causing a prosthetic joint infection if candidemia occurs. So it's not an uncommon thing, but of course, in our country, in our settings, always the gram-negative bacilli are the top, the top culprits for this PJI. So, what further? In terms of whether it's uncommon, no, it is definitely a known thing. It's a very well documented entity, I think.
I hope it answers your query, Dr. Shilpa. Our next question is for Dr. Rupa. How to collect sample in case of suspected biofilm formation in prosthetic if the prosthetic is placed? Or maybe even Dr. Alankar can take this question. How to collect sample in the case of suspected biofilm formation in the prosthetic, from Dr. Lakshmi.
Okay, so can I go back to the first question and also maybe add a little bit to it? So if I'm sending a sample suspecting a periprosthetic joint infection, if I send a sample and nothing grows and I'm like really sure of the infection, I would definitely ask my microbiologist that I also am looking for a fungal infection. So we have seen very rarely, but definitely we have seen fungal infections. So if routine bacteria cultures, we don't grow anything, we would definitely request our microbiologist to see if there is a fungal growth. And that will take a lot of time. And the second question, how to collect sample in the case of a suspected biofilm formation. So in our routine practice, we don't suspect that there is a biofilm formation. We suspect whether there is infection or not. So we collect samples to diagnose whether there is infection or not. And biofilm formation is a byproduct or natural occurrence after any infection, mostly gram-positive infections. So we will not collect samples differently if we suspect biofilm infection. So I think that is, and the second important point I would like to mention here is antibiotic-free period. Generally, the first response of all my colleagues and most of my colleagues is, if you're suspecting infection, start antibiotic, which is not the right thing to do. You first find out whether there is definitely infection. So the clinical science and all this blood tests, ESR, CRP, we do this routine blood test to see if they are raised, and as compared to pre-op, if there is a rising trend, then we would suspect infection. And if we are suspecting infection, we would stop all antibiotics, take a sample after at least 2 weeks of antibiotic-free period, and make sure that we get a sample from the joint. For knees, it is very easy. You do all aseptic precautions, and some people recommend you do it in the OT, but I do it wherever in a clean environment, I first encounter the patient. It could be the emergency or in the wards. But then standard is you go and take it to the OT, but then there are a lot of issues involved. So I do it in the ward or in the emergency, wherever I see. So all aseptic precautions. And for knee, it is a very accessible joint. We can easily get a sample. But for a hip, it is very difficult for you to get a sample. So usually image-guided samples are being taken. For hips, I have found that if you do a CT-guided aspiration of the hip, if you are suspecting periprosthetic joint infection and there are radiological signs to suspect that there is lysis, loosening, and you suspect periprosthetic infection. So for a knee, it is easy. You can just go percute and get a sample. But for a hip, I would do CT-guided aspiration. Some people do image intensifier guided aspiration, but it is difficult. So CT guided is one. Second, all these samples I'll take 2 different samples. One, I would take a sample in a aerobic culture bottle. There are less chances of contamination. And I would also take another sample in a sterile container where I would add
Normal saline.
No, not normal saline.
Sterile distilled water.
The anticoagulant.
EDT.
Heparin, yes. Yeah, I would add heparin so that we can send this sample for routine microbiology and gram staining. Yeah. To see the sugar levels, all those things. So many times we just take the sample and send it for culture. It is also important for us to take the sample to do all these routine investigations. For example, cell count, differential neutrophil count, and differential count, as well as sugars and all those things. That is what I would do.
Okay, thank you. Our next question, maybe I'll request Dr. Rupa to take in. If MIC is 1 for vancomycin, do you suggest vancomycin E-strip for MRSA?
So in this particular case, I think they have done the MIC. If you are doing Vitek testing, so we will get the MICs anyways. In this, e-testing was done because the patient was not responding. Is it the reason that you did the e-testing?
No, ma'am. Even automated methods are not recommended. Ideally, specifically mentions like we have to do either by e-strip or the
Vitek did. Okay. That could be the reason why it was done. Okay. So practically, we have to get a e-testing done if you are if the patient is on treatment. Then if that is what is the case, then we have to do the e-test.
Thank you, Dr. Rupa. Our next question is from Dr. Shweta Shah. Maybe I'll request Dr. Vidyulata to take the question. Initiating cefazolin and vancomycin 2 drugs, or what is the usual protocol? And how common do you see gram-negative bacteria in PJI before 6 months of surgery?
So usually, if there's a gram-positive organism, adding both vancomycin and cefazolin is not the dictum. I mean, because we would have the susceptibilities within 24 hours. If possible, one would add daptomycin because it's a very good drug for MSSA and MRSA both. The question arises that vancomycin is clearly inferior. However, if it is a very sick patient, then yes, I would definitely, if I cannot procure daptomycin, then vancomycin and cefazolin to make sure that the Staph aureus, MSSA, there is methicillin sensitive Staph aureus, is well covered. Because I believe that you would know that there's a GPC in the blood awaiting the IDN sensitivity the next day. So in that case, you want to even make sure that other gram-positive organisms are also covered. So your enterococcus and everything will get covered with your vancomycin. And if it's a very sick patient, definitely I would add if daptomycin cannot be given for whatever reasons. And the second question was?
GNB.
How commonly do you see gram-negative bacteria before 6 months of surgery?
We commonly see gram-negative bacteria only. I mean, the Staph aureus and all, definitely our main problem is gram-negative, and within 6 months, that's the common, I mean, it's a common time of presentation for these prosthetic joint infections. So yes, it's rather common than uncommon, I would say.
Okay, and in India, being TB endemic, so use your comments on use of rifampicin for PJI infection.
So strictly for prosthesis in situ, not for a native for a osteomyelitis. If it's a prosthetic joint in situ, then yes, we've used it, but because it is documented to, give efficacy in such situations. So yeah, that monoresistance and all, we don't have that so much of a problem. The INH monoresistance is much more of an issue rather than rifampicin. So I think, when you clearly know that there's no tuberculosis in the background, in the sense, in that clinical entity, then you should be comfortable using it.
Okay. The next question is from Dr. Aarti from Chennai. Vancomycin MIC in this case was 1.5, which implies reduced susceptibility. Can teicoplanin be given in such cases? Also, what was the indication for cefazolin? Maybe the speakers can answer. And do we need to give a combination therapy?
Yes. So basically, yes, as I mentioned, vancomycin MIC creep, it is still in the susceptible range. And as I mentioned, persistent bacteriemia, the treatment of choice are the combinations. Daptomycin would have been the ideal choice, as I mentioned, because of the cost as well as the procurement issue. We couldn't start that patient on daptomycin. Otherwise, ideally, I would have started the patient on daptomycin combination therapy. Now, because of in the current scenario, the best we could do is this, and it has all. There are various studies which have demonstrated this synergism, and that is why we had initiated on teicoplanin plus cefazolin. Teicoplanin because the patient was in AKI as well as it has a better bone penetration than the vancomycin.
Yeah. Okay. Dr. Vidyalata, can linezolid be used as an alternative therapy for MRSA PJI?
I prefer not to use it. It is a static agent and not a sidal agent for MRSA. So in presence of prosthesis, certainly sidal agent is desirable. So in fact, there are many times where people have documented failures in that case. So definitely a sidal agent is preferable.
Thank you. And thank you, Dr. Aarti from Chennai, for your questions. And I hope every question is answered. The next question again is for you, Dr. Vidyalata. If PET is available, will TEE still be preferred?
I think if PET scan is available, TEE, will it still be preferred? They're different. I mean, see, metastatic foci, if you're looking at that, like Dr. Alankar had mentioned that, that they were lucky in having a localizing sign. Usually with Staph aureus bacteremia, you may not have a if there was no localizing sign, and if the patient's fever is not resolving, or you have a recurrent positive cultures, then to look for a metastatic foci, maybe PET scan is better. But all the PET scan does not tell you about the infective endocarditis so reliably. It is for brain and for heart, you may require specific invest. So if you are thinking in terms of endocarditis, then definitely TE is a preferred modality. PET scan, I would reserve it for a metastatic foci, if I want to look for a metastatic foci. So see, in Staph aureus bacteremia, there are clear-cut indications where a TE is needed. And usually those indications are when there is an underlying valve condition, the patient is an IV drug abuser. So various valve conditions are mentioned, like prosthetic valve, the patient has a, mitral valve disease, and there is a whole list of valvular conditions where a TE is mandatory. And in other cases, your 2D echo is fine to rule out endocarditis, but PET scan per se will not be the preferred modality to rule out endocarditis, but for a metastatic foci, yes. Like pyomyositis and all those things will definitely be very well picked up if you are looking at a, in a Staph aureus or bacteremia where the patient is not getting better.
Thank you.
So if I can add.
Yes, sure.
Basically, even we had a patient, specifically a patient who was had the vegetation in TE demonstrated, and PET scan showed no vegetation. So PET scan cannot be used to rule out any vegetation, especially in infective endocarditis. TE, if you can do it, you can do it as a combination than as a one-on-one. And another thing is there are few scores which can be used, like for determining VIRSTA score and positive and PREDICT score are available. Just in case, you can do for indications for TE can be taken through those scores.
Thank you. Next question, I'll request Dr. Alankar to answer. Which antibiotics are used for pre-surgical prophylaxis in open fracture patients, and for how much duration? This question is from Dr. Vikram Kumar from Raipur.
So, depending on what contamination is there and, for example, what is the level of contamination of the wound, the surgeon has to decide. But in our teaching days, so I don't see open fracture wounds anymore. In our teaching days, we used to add metronidazole also in addition to routine antibiotics. So we used to add 1 gram positive, 1 gram negative, and also metronidazole. Yeah. And for how much duration? So infection is not established yet in an open fracture. So if you do early debridement and a thorough debridement, probably you also take away a lot of bacterial load and then you cover it just because. And then there are various core orthopedic questions here. For example, whether you would do, depending on how much is the grade of open fracture. For example, it is 3A or 3B, depending on what it is. So you may not go in for a open reduction internal fixation. You might use a external fixation for this and see that there is no infection. You can do proper debridement and you can do dressing. And then if there is evidence of sepsis, you send it for culture sensitivity, grow a bug, and decide what you would use. But I don't think our surgical prophylaxis changes according to, it is routine prophylaxis, and depending upon what your infection control department, what are the practices in your hospital.
Okay. And one more question to you, Dr. Alankar. What's the role of chlorhexidine bath on day of surgery?
Yeah, it is recommended across the world, and all standard societies recommend using chlorhexidine bath on the day of surgery or before surgery. At least 1 bath with chlorhexidine. And in my hospital, we do 3 baths and also paint. It is recommended. It is a good thing.
Sure. And one more question for you. Most often we are unable to find the source of SSI post-joint replacement. So any inputs towards finding source in such cases? This is from Dr. Vidya Pai.
Source of SSI. So probably I think the question is, maybe Dr. Vidya means to say that we don't isolate an organism or a bug. If this is the question. So probably what I said is antibiotic free period, getting a sample and then sending it for culture, and maybe serial subcultures. Sometimes they don't grow anything for first 2-3 days, but continuing to grow them for 7 days and beyond, and it might grow some organism. So whether you have an organism or not, it makes a lot of difference in your treatment. The prognosis is much better if you know organism and sensitivity. And if you don't know organism, you are like, you don't know, you're just playing in the dark. And source of infection, I don't know. Maybe this is what Dr. Vidya meant. Did you mean organism? And I think I have answered
Yeah,
that.
maybe culture negative. Yeah.
No, I think she means, is there a hematogenous, meaning,
Okay.
is there a remote site infection? I think that's what she means.
Yeah.
A remote site infection, seeding this
So-
particular site.
I think depending on the time since surgery, when the patient presents to you, for example, if the patient presents to you within like 1 month, you know that definitely, and the wound is oozing and or you're suspecting that there is infection. So this is definitely exogenous. You have given it to the patient from the hospital or in the OT. Even delayed within 3 months to 24 months, there is very high possibility that this is exogenous. And then there is something called as late infection, which is beyond 2 years. So this is mostly hematogenous. So there is a lot of literature which supports this statement that I'm making. And sometimes there is another category of patients where they are like really silent infections and you see this purulence or signs of infection only while you are revising them. So this is probably also exogenous. You have given it to the patient during the time of surgery from either the surgeon or the OT or the CST.
Thank you. So we would like to move on to the next case presentation, and I think we've answered majority of the questions from the audience, but still we'll go through the questions, and if the questions are pending, we'll email to the experts and get back to the audience. But right now, with due respect to time, we would now like to move on to the next case. Dr. Darshan, can you please load the introductory slide for our next speakers for case 2? So our second case is titled Single Stage Revision for Infected Total Knee Arthroplasty. We have Dr. Anisha Maria Fernandez with us as the speaker. She is Assistant Professor, Department of Microbiology at Kasturba Medical College, Manipal. Previously, she was the Consultant Microbiologist and HIC Officer at AJ Hospital and Research Center, Mangalore. Also, she's been the Consultant Microbiologist, Quality Manager and Laboratory Safety Officer at Columbia Asia Referral Hospital, Yeshwantpur. She's got 10 publications, both in national and international journals to her credit. Along with her, the next speaker is Dr. Fawaz. He's a fellowship trainee in hip and knee arthroplasty and arthroscopy in KMC, Mangalore. And we are happy that we even have Dr. Yogesh Kamath, who is logged in with us. He was the treating surgeon in this case. So over to you, Dr. Anisha. Requesting you to please share your screen and begin the presentation. Thank you.
Thank you, Dr. Pooja. The slide, is it on slideshow?
Yes, we can view your slide and hear you. Please proceed.
We'll start the presentation. I'm Dr. Fawaz Shike. The topic for our presentation is single stage revision for infected total knee arthroplasty. And the introduction is periprosthetic joint infection is a devastating complication following total knee arthroplasty. As you all know, the diagnosis and treatment of these periprosthetic infections is a challenging task as it requires precise identification of the pathogen, meticulous debridement, and eradication of the infection. History: Mr. RP, an 82-year-old male who was previously independent and moderately active individual who used to drive himself, runs an estate and travels abroad twice a year, which shows he was very active. And he had recurrent UTIs in the past and with recurrent cellulitis for which he was treated by antibiotics in the form of cephalosporins, tetracyclines, and penicillins. And so he had been taking n number of antibiotics for the same. It comes to us with an unhappy troubled left knee in 2021 with initially pain, which was initially more on the anterior medial aspect of the knee. Then he had pain in the patellar tendon insertion, and the pain was initially insidious onset, which was throbbing and gradually progressing. And swelling initially it was extra-articular, and gradually it became intra-articular with gross effusion, with inability to bear weight and with restriction of movements in the knee joint. And On examination, he had 15-degree fixed flexion deformity with further flexion of 90 degrees. And for the left knee, he had undergone many multiple surgeries in the past. In 2007, he had undergone a total knee arthroplasty for the left knee with revisions in 2014 for a fractured poly, and in 2016 for a patella spur excision in the left knee, in the same knee, and in 2019 for implant failure at femoral system junction. He is a known case of ischemic heart disease and 2 times deep vein thrombosis, one for which he is on blood thinners. This is the pre-op X-ray. That's the X-ray following the initial revision, wherein you can see the implant hinged constraint implant where the patella is being resurfaced. In the subsequent X-ray show the patella button fracture with possible breakage at the femoral stem junction, and which was confirmed in the further repeated X-ray. The break in the femoral stem junction can be very much visible with the patella button, which can be visible in the posterior part of the knee. And the plan of action for the case was, we had stopped all antibiotics prior to the surgery, as he was on multiple antibiotics which was given from the father centers, and his knee was aspirated, and aspirate was sent for the microbiology and pathologic investigations, and we had looked for inflammatory parameters. And now Dr. Anisha will take over from here.
So the initial pre-op investigations that were sent on the day of admission were routine, of which the CBC, if you can observe, the CBC was only slightly raised WBC count, and the lymphocytes were low. The inflammatory markers, that is ESR and CRP, were investigated, and CRP was 20.9 mg per DL. Both were raised. So initially also, because of the in view of the recurrent UTIs, urine was sent for culture and sensitivity, and we were able to isolate E. coli, that is a ESBL strain. On day 2, that is the day of surgery, pre-op, synovial fluid was sent for culture, and it was sent as an automated culture in our pediatric automated blood culture system. And this is a common practice here, where one sample is sent in the blood culture system, but another sample is also sent at the same time for a gram stain. But in this case, because there was a very limited amount of synovial fluid that was that we were able to aspirate, it was only sent solely in the blood culture system, that is our BACT/ALERT. And this flagged positive in 9.5 hours. So gram stain was done from the bottle, and we were able to see gram-positive cocci in pairs and chains. This is our gram stain. So this coincided with our intra-op samples that we received. We received 5 deep tissue samples. 4 of the 5 samples showed numerous pus cells with gram-positive cocci in pairs and chains. 1 of the 5 samples had a very few pus cells and no organism was observed. Additionally, from the deep tissue, microscopy was requested for fungi and for mycobacteria. Both were negative. A gene expert was also done for TB, which was negative. And culture for fungi and for mycobacterium was requested. So 2 days following the surgery, that is day 4, we were able to report the synovial fluid culture and sensitivity report. This is from our BACT/ALERT system, our automated blood culture system. And it grew Streptococcus agalactiae, that is group B strep, which was sensitive to penicillins, levofloxacin, vancomycin, and linezolid, but was resistant to tetracycline. Similarly, from 4 of the 5 deep tissue samples, we were able to isolate Streptococcus agalactiae, that is a heavy growth of the organism, which showed a similar sensitivity pattern, that is sensitivity to penicillins, levoflox, erythromycin, vancomycin, teicoplanin, and linezolid. And this is the gram stain of our deep tissue. So this was seen in 4 out of the 5 samples. In one of the samples, we did not get any growth. That is the smear negative sample. So following our incubation period of 2 weeks and 8 weeks respectively for fungal and mycobacterial culture, we were able to report that both were negative. So our the timeline of our inflammatory marker investigations. So prior to surgery, both were raised, ESR and the CRP, which I've already presented to you. Day 2 was the surgery, and around 9 days later on day 11, ESR was still raised and so was the CRP at 28.4, but we can consider this to be normal following a surgery. By day 16, CRP had resolved to normal limits. That was 8.4 mg per dl.
So based on the proposed definitions for prosthetic joint infection, we had definite evidence of identical microorganism isolated from 2 or more cultures, which was in evidence of the prosthetic joint infection. And the surgical plan, as you all know, could be a single stage revision or 2-stage revision. Ideally, when the patient presented, we thought of going for a 2-stage revision because the multiple revisions which he had had in the past. But considering his age, the low virulent organism, and the comorbidities wherein he is a cardiac patient with 2-time vein thrombosis, wherein if you go for a 2-stage revision, you have to keep a cement spacer in which you have to immobilize for a long period. And the patient preference was he don't want to be immobilized, he want to walk on the same day after surgery. So following this, we have planned for a single stage revision. And the management should be a multidisciplinary management wherein a microbiology plus pathological management is of utmost importance, as the microbiologists helped us in getting our intra report within half an hour, which helped us in coming to a diagnosis, like plan for the surgery, wherein they have been bacterial isolation plus sensitivity and infectious disease specialists who helped in selection of sensitive antibiotics for us, and the specialist revision surgeon who has done the thorough radical debridement plus selection of the complex implants, and an anesthetist plus specialist nursing care for delivery of local plus systemic antibiotics through a PICC line. So this is the intra-op image of the patient after the removal of the tibial stem with the insert, wherein you can see the defect in the tibia, metaphyseal part of the tibia, and with the femoral implants too. This after the removal of the femoral and tibial stem, wherein you can appreciate the thoroughly removed debrided synovial tissue with the bone particles with the implant particles. After the removal with copious pulse lavage wash with gentamicin, we were ready for implantation. And the proximal part of the defect was filled with the metaphyseal cone, tibial and femoral part. And post cementing and implantation, this was the final picture we have got. And post-op X-ray, wherein you can appreciate the implant in epi and lateral view with similar beads, which can be seen here, which was a hinged implant, modular rotating implant, hinged implant. And the antibiotic management, as we all know, preoperatively we have stopped all the antibiotics, and intra-op we have used a Paracos antibiotic cement with which was mixed with vancomycin in vacuum, and stimulant beads which mixed with ceftriaxone plus vancomycin was used intraoperatively. And postoperatively, after a discussion with the microbiologist and infectious disease specialist, we had based on the sensitivity, culture and sensitivity, we had put him on ceftriaxone plus sulbactam 1.5 gram IV BD for 8 days, followed by ceftriaxone 2 gram IV OD for 4 weeks, and followed by oral linezolid 600 mg for 2 weeks. This was the patient video which he had sent to us after 4 weeks, where you can appreciate him walking in the water comfortably in his house. And he was very much happy that he could bear the funds probably. And discussion part of and post 1 year, the patient is now very much happy. He's able to drive his car. He's still very much into his business. He's traveling abroad still. And he had recently sent us a testimonial saying that he was very happy with the result which he has come across after 1 year. Now the discussion part, Dr. Anisha will.
So Group B streptococci is not uncommon as an invasive infection. However, with regard to bone and joint infections, it is associated with prosthetic joint infections, native joint septic arthritis, osteomyelitis, and even spondylodiscitis. When it comes to prosthetic joint infections, it is associated in approximately 10% of cases. This is second only to Staphylococcus species amongst the gram positives. It is commonly seen as a delayed onset or even a late onset, that is anywhere between 3 months to 2 years, and late onset is more than 2 years following the insert of the prosthetic joint. The source commonly is gastrointestinal or even genitourinary, and it can also be found to colonize the skin. So in our case, we weren't able to isolate. I think that was a question during the discussion of the previous case as well, that detection of the source is important, but in some cases we can't identify the source. And in our case also, we couldn't identify the source, but we had that supportive history, suggestive history of repeated urinary tract infections. And even in literature, if you go and see similar cases for Group B strep causing prosthetic joint infections, many case reports say that they have searched for the source of infection but could not find it. But again, they had suggestive history like recurrent UTIs, and even in one case, a few week old history of a gastrointestinal upset prior to the onset of these symptoms. Risk factors, it's commonly seen in elderly males above the age of 65 years with comorbidities, especially diabetes mellitus, chronic underlying diseases, especially SLE. Smoking is an important risk factor, alcoholism, drug abuse, especially prolonged corticosteroid use, any immunocompromised or immunosuppressed state, previous local surgical interventions, or a previous prosthetic joint infection. So a study in 2016 published by Seng, they studied a series of cases, around 36 cases of Group B streptococcal prosthetic joint infections in which GBS was the sole etiological agent. But a similar study published in 2021, which was a 7-year period almost along the same time, that was 2009 to 2015 by Lube. He states that in 24 of the cases that they examined where GBS was an etiological agent, it was associated with either Staphylococcus aureus, cons, or even Enterococcus faecalis. Higher remission rates are seen with all streptococcal species causing prosthetic joint infections, including Group B strep, but amongst the strep species causing PJIs, it definitely has poorer outcomes. The reason for this is unknown. So a study by Pio in 2016, whom they monitored their cases for an average period of 3 years post-operatively, and they found that the remission rates was around 70.5%, but the poor outcomes were seen in 58.2% of the cases. The possibility here is that risk factors do play a role, and even management plays a role when it comes to the outcome. So high failure rates were especially noticed in patients with diabetes mellitus, especially uncontrolled, and also where the implant was retained. So management, commonly it's advocated to do a thorough debridement, targeted antibiotic therapy with or without the implant removal. That is at the discretion of the orthopedician. But again, like I said, implant removal, implant retention is associated with a higher risk of failure. failure in terms of recurrence of the prosthetic joint infection with the same organism or even another organism, or even a mortality. So currently the antibiotic therapy recommendations by the IDSA, that is the only guideline available, say that penicillins are the drug of choice, and the duration of therapy should be prolonged from around 4 to 6 weeks, and that was followed in our patient. However, penicillins do have the risk of not being effective if there is a static phase of the bacteria. That's especially seen in biofilms. That's possibly one of the reasons why implant retention would result in a failure, because you're allowing the biofilm to be in situ still. So FIO in 2016, the same article suggests that all antibiotics have to be stopped pre-op, and in fact, no preoperative prophylaxis should be given as well. So that was followed in our patient. Intraoperatively, they advocated broad spectrum beta-lactam antibiotics with an MRSA active agent. And then this is modified once the culture sensitivity reports of the intra-op samples are made available. They also advocated the combination of rifampicin with levofloxacin, which they found to be effective in many of the cases that they had reported. So the take-home message here, it's very important to have good coordination between the surgeon, the lab, and the ID physician. This helps in a tailored management and better outcome to the patient. We do advocate automated blood culture systems wherever possible for not just blood, but body fluids as well, sterile body fluids. So the pediatric blood culture bottles should be used, and this is something that is done across our hospital. Whenever you have a delayed or late onset prosthetic joint infection, do keep in mind group B streptococcus as a possible etiological agent. Always look for a polymicrobial etiology, not just bacterial, but even fungal, because I think one of the questions was fungal etiology PGIs. They are commonly seen as associated with bacterial infections. They're not the sole etiological agent in a prosthetic joint infection. Search for the source, or at least so that means multiple cultures from various sites if possible, and at least try and elicit a suggestive history which would guide you to identifying what is a potential source. Currently, we only have the IDSA treatment guidelines, but since group E strep is gaining interest as a cause of PJI, mainly because of the not so good outcomes, we may have better guidelines in future. The prognosis and the outcome depends on the control of the underlying risk factors wherever they can be mitigated or controlled, and also the management protocol, whether there's a retention of the implant and the antibiotic regime that is used. So these are some of our references. And thank you for your patient listening.
Now I would like to call upon Dr. Yogesh for his is the primary management care and decision maker at the time of surgery.
Thank you, Fawaz. I only wanted to just add a couple of comments, because as our presentation was going on, there were a couple of questions which I was answering to from the messages there. We unfortunately missed out in our presentation that oral antibiotic prophylaxis was continued after the initial 6-week IV regimen that was given. So that is, there are no clear guidelines as such on how long this should be continued for, but the patient was wary of taking antibiotics for too long. However, we convinced him that he should take something for a period of at least 3 more months. So with our infectious diseases consultant, we managed to give him basically Augmentin. Because following the cephalosporins, obviously we couldn't give them orally, and he wouldn't take IV for too long because the central line that was put initially then got infected at the 6-week point. He had gone back to his place, having traveled far to come and get the operation here. So then we had to continue oral for an additional 2 months following the stoppage of IV antibiotics. This is another point which we'd love to discuss because there are no clear guidelines as to how long this should be continued. So that's probably another take-home message for us. But thank you to Dr. Anisha and Dr. Fawaz for presenting the other aspects of the case so beautifully. We'd look forward to comments from the moderators and questions. Thank you.
Thank you to all our 3 speakers for the detailed case presentation. I would request Dr. Alankar to give in his comments or question to the presenters.
Thank you so much. Congratulations, Dr. Yogesh and Dr. Anisha and Dr. Fawaz. I think this is a very good case. I think with his age and comorbidities, I think you decided to do a single stage revision and use a hinge. I think so. For the benefit of our audience, when you do a debridement of the knee, you want to take away anything that is infected or doubtfully infected. So if you want to do a single stage, the standard is, or the most acceptable treatment is 2-stage revision. So you do a first stage, you take the infected implant out, and then you put a cement spacer according to antibiotic culture sensitivity. And then after 6 weeks, once you are convinced that there is no infection or the infection has gone down, you go in and put another implant there. But if you want to do a single stage revision, you have to take away anything that is doubtful or infected or doubtful. So here you have to take away the collateral ligaments as well. So you have to use a special type of implant called as a hinge knee, which Dr. Yogesh has used. So I think they have done all the things, looking at the patient's age, and they have used the hinge. I think they have done debridement. So there are few things which I found not, I did not probably, I would mention them. So doctor mentioned that there was limited sample from the knee, which is like really unusual for a knee. I have had, unfortunately, a fair share of infections in my practice too. And knee is such an accessible joint. Probably it is very unusual to have limited sample from a knee. Usually people have significant tissue available, maybe because there's so much effusion because of infection. So maybe this was a rare case. And single stage you have done well. And do you do some kind of frozen section intraoperatively for if you are planning to do whether a single stage or 2-stage? That is one question. And one more observation is, I saw that you did not add rifampicin. I think there is a lot of recommendation, and even the Americans, Europeans, they add rifampicin to this. There is publication everywhere. Why did you decide not to add oral rifampicin to this patient post-op?
Can I start with answering that, and Dr. Anisha could probably chip in?
Yes.
So one was definitely we did a thorough debridement. He was a bit fidgety. He had a very, to answer your first question about the limited sample, I had to collect the sample at a different hospital. So he traveled 400 kilometers to come here. So at the hospital, fortunately, I had automated culture. But he was fidgety. He'd had a previous experience from having a knee joint aspiration elsewhere and was very, very apprehensive when I was collecting the sample. So he moved and my needle got blocked. So at that point, I got a speck of blood at the end of the needle. So to maintain asepsis, I clearly had an effusion there. I could have clearly got additional 10 to 20 cc. But at the point where the needle got blocked initially, I didn't want to fidget around further into the knee by going in and out. Rather, the 7 cc of sample which I'd got, I just directly put into a pediatric blood culture bottle. So that is why I did not put the needle again, to avoid any further risk of contaminating the knee. That's number one. Number two, rifampicin was not given after discussion with the ID and the microbiologist here, because we had a good range of antibiotics he was showing good sensitivity to. So both from the side effect profile, the point that we had good sensitivity to cephalosporins, and 3, he was having documented side effects of vomiting with a lot of antibiotics. So we thought he's tolerating that well. 3, we've got local delivery of antibiotic because of the calcium sulfate beads, where we know antibiotic would go into the tissues over a period of 6 to 8 weeks. We thought it was fairly okay not to go overboard and give him rifampicin. And of course, the thing we have in our country, like we've just discussed with the last case as well, that rifampicin can be given to people who don't have any TB, but we didn't want to. Our microbiologist just doesn't recommend it as a first line, just as a antibiotic in case we increase chance of resistance for rifampicin. So we did not use it as a first choice.
To add on to what Dr. Yogesh said,
yeah,
I just brought in that point because our usual protocol is that the clinician sends us a sample for gram stain as well as a sample in the automated blood culture system, so that we can immediately give them the gram stain report from the synovial fluid itself. So that was the only thing that went out of the usual protocol for this patient. Otherwise, immediately in the pre-op, it was a possibility that we would be able to report the GPC in the gram stain itself. But that was not possible in this case because of the paucity of sample. And secondly, yeah, what Dr. Yogesh said, we do tend to hold rifampicin as our reserve drug for, because of it being an anti-tubercular first line. We tend to hold on to that. And since there was a implant removal in this particular case, we didn't see the likelihood of it failing, and the ID physician concurred with us. So we felt that we could be on the safer side, even though we were giving cephalosporins.
Thank you. I would request Dr. Vidyalata to put in her comments and questions for the speakers.
Yeah, first and foremost, was this, was this patient a DVT on some sort of a anticoagulant? Actually, that is the reason why your ID consultant must have said no to rifampicin, because there will be a lot of drug-drug interactions. So was this person on anticoagulants? Is that question? Is the question. That is why I actually raised my hand.
Yes, so, madam. He was rather on a high dose of factor 10A inhibitors. So
that is the reason why they would have chosen not to, because we just can't afford those levels going down. And so that may be the reason, one of the major reasons why rifampicin was not advised in this case. Secondly, lot on that, you said 6 weeks of, the oral antibiotic choice was what, linezolid only?
Yeah, it was initially linezolid, but then he was not tolerating that well. So we had documented sensitivity to a large number of antibiotics, including even basic penicillins. So we then gave him penicillins orally, and I think then he had some issue with penicillin. So for the last 2 to 3 weeks, he might have taken, I can't remember off the top of my head, but he might have taken even ciprofloxacin for some time.
So basically, the Streptococcus agalactiae is a disorder of the elderly people. And the most important thing is that it is associated with malignancies, as well as your chronic lung disease, chronic kidney disease, and all the other comorbidities that you mentioned. But malignancy was missed out over there. Secondly, GI and the genitourinary and the gastrointestinal tracts are the most important sources of these infections. It is not as common a source for cellulitis as Streptococcus pyogenes is. So Streptococcus agalactiae, the very likelihood was GI or GU source with that intermittent bacteremia, which may have got, they wouldn't have realized it, and that's how it's seeded. So you have the other side also in actually in situ. That joint. So the patient was lucky, I would say, in that sense. But And the thing is that there's no rationale for ceftriaxone sulbactam. Many people have commented that on the chat box, because the mechanism of resistance in these species is that of alteration of binding PBPs. So in those cases, there's no role of adding sulbactam. So you straight away go to vancomycin if you're, or one might choose to add a gentamicin as an additional, coverage for that particular thing. But there is no rule of using ceftriaxone with sulbactam in the management. Ceftriaxone alone 2 gram IV OD is enough, and usually oral therapy can very well be cefalexin or amoxicillin. Of course, with the prosthetic joint, here rifampin would have been desirable, but in your case, protecting the anticoagulant was probably at the top priority. That's why oral and your surgical debridement and your all inflammatory markers were all clear. So maybe with regards to that, otherwise cefalexin or amoxicillin is enough for the Streptococcus agalactiae later on after 6 weeks of intravenous antibiotic therapy. With regards to duration, we have always used 3 months in such cases. And the latest NEJM article in May 21 actually said whether we can make it 6 weeks, and they have demonstrated non-inferiority in that. However, personally, you would like to have extended up to 3 months still. No much their personal experience with just using it for 6 weeks in such cases. So that was on the use of oral antibiotics later on, the ceftriaxone sulbactam, and always screen the abdomen when you get agalactiae, because you might have a source over there. We've had people with polyps, even malignancies. So you have to always look for the GI. You have to image the GI. Do at least a sonography to make sure that you're not missing out on something. So chronic liver disease, intestinal malignancies, GI malignancies, they are always to be thought of when you see agalactiae, because agalactiae it's not the commonest cause of your cellulitis, that is strep pyogenes. So here the source is GI or GU, and you have another joint, and it is probably bacteremia, which anyway 2019 was the last surgery and 2021. So anyway, you have covered 2 years. So that is, these are the things that I would highlight here in this case.
Yeah, just one
so monitor
reply
CRP
to your comment. Yeah. The choice of cefeprazone sulbactam was not to counteract the streptococcus, madam. It was
it is
only
ceftriaxone sulbactam. She mentioned ceftriaxone, not cefoperazone.
Sorry, cefeprazone sulbactam.
Ceftriaxone sulbactam. She used ceftriaxone sulbactam.
It was Magnexfort. So I think it's cefeprazone. Yeah. So that was only in because we already had vancomycin and we had gentamicin in the patient locally. The cement we used with the prosthesis has gentamicin in it. So that is going to be released into the local site over a period of 6 weeks. We had calcium sulfate beads, which were dissolving with vancomycin into the medullary canals before the prosthesis implantation and all around in the soft tissues. So locally, the patient was getting enough vancomycin. So the idea was to attack it because we are doing single stage. We've had our surgical extremely thorough debridement, including debridement of everything apart from the vessels, that is including the collateral ligaments. And we've got a lot of local vancomycin and polyantimicrobial therapy, really, vancomycin and gentamicin going there. And in addition to that, we've got ceftriaxone going IV. The cefeprazone sulbactam was only because we had an initial aspirate, and we can, in such cases, we may not be sure there could be a polymicrobial growth. So it was only to cover in case there was a polymicrobial growth until we got a definitive report from the tissue samples, intra-op tissue samples. That was all, madam.
Understood. So she had mentioned ceftriaxone, the slide mentioned ceftriaxone sulbactam.
Okay. Oh, I see. Yeah. So we generally give that our microbiology.
So understood. Yeah. You use cefoperazone sulbactam empirically till you got the final cultures.
Yes. But so that is acceptable.
The mention was of ceftriaxone sulbactam. That's why the comment.
Sorry, ma'am. Yeah.
I would request our next expert, Dr. Rupa, to give in her comments or any specific questions for our speakers.
So, can you all hear me?
Yes.
Very well, madam.
My internet is quite unstable. Oh, okay. So, this is another interesting case where when we see many gram-negative organisms growing in periprosthetic infections, here we are seeing another gram-positive organism which has come in this particular case. And typically here they have taken 5 samples from the sites, and that is what is the recommendation. At least 3 to 5 samples are necessary, and literature also mentions that the percentage of the infection is 3% in if there is no cases, no growths in these cultures, to around 94% if you are getting growths in about 6 samples. So obviously it was a right decision, and we also look for around 3 samples at least.
I think there's some network issue at Dr. Rupa's end. Dr. Rupa, are you with us?
Dr. Pooja, if you can go over the questions, unless Rupa is back, Rupa can speak.
Am I audible now?
Yes.
So I don't know where I missed you out.
15 minutes.
So typically, so what I was saying is that the number of samples have to be more. At least 3 samples are minimum requirement, and these have to be once they are cultured on conventional medias, they have to be kept at least for 15 days. They require longer incubation for the better yield of the organisms. The blood culture systems have found to be more effective because the yield of the organisms is faster. So that is the other thing that needs to be considered. Also, there was a question about whether there are any molecular methods of diagnosis, and yes, 16S RNA PCR is recommended. However, these samples have to be not collected only in a sterile container. Heparin should not be added to that, because heparin would be an inhibitor of the PCR, so the results might not be proper. So the other thing is that both the cases, having one interesting case is that in spite of being 82-year-old with comorbidities, these patients have all recovered wonderfully with the appropriate therapy. So that is a big cheer to the 2 teams, and it also brings on a lot of encouragement for us. Sonication is another methodology that one can follow. Sonication is another method that one can follow as far as the prosthetics are concerned for better yield of the organisms, and we have enough experience to show that they can yield organisms much better than the routine cultures. The other thing is something that I would like to ponder upon is that if we really would this be of great use if we educate our patients and the relatives, making sure that they prevent any kind of infections post surgery, so that hematogenous seeding of the joints is prevented, and the joints can, the prosthesis can be saved for a longer time. So these are the things that are from my side with regards to this particular case.
Dr. Rupa, if I may answer to a comment of yours, the most fantastic joy for us has been very good reciprocation and direct dealing with our microbiologists. So what exactly, like you say, we have changed our protocol recently from sending direct sample to sending samples in the automated test, because whatever said and done, even in the 10 minutes that it takes for the sample to reach the lab, we can probably have some labile organisms not being able to withstand that transfer and not being grown. So we directly inoculate within a minute of aspirating it from the joint. So what we do is, if we get limited sample, we keep both, and this has all been with repeated meeting and developing a protocol with our microbiology team. We've got very enthusiastic microbiologists with us, thankfully. So if we get limited samples, we put it in a pediatric blood culture bottle. If we get a 10 ml sample, we put it in an adult bottle, and we put it in an EDTA bulb, because we are doing cell counts of these, because that gives us a probable evidence of infection with something like 80-85% accuracy. I had done that study myself, and we got that when we published it in, and I was in England at the time. So we just, from the cell count and a differential count of the synovial fluid, there is an 80 to 85% predictive accuracy of it probably being a periprosthetic infection. So a cell count of more than 2,800 per cubic millimeter and more than 80% neutrophils. So depending on the quantity of sample we get, our order is first just the blood culture bottle, then the EDTA, and then the additional free sample for gram stain. Now this is pre-op. Intra-op, it's got to be tissue. And fortunately, they say the tissue sample retains the organism for longer. So it's from the orthopedic side, even though it's about 5 samples are usually sent, it's got to be 5 from 5 different sites. So the best sample for me is actually, once I extract the prosthesis, the part of the tissue under that prosthesis, which I believe is where the microorganism harbors first, the greatest, or the area of the greatest avascularity, where the you can say osteomyelitis has begun to happen. And we have now actually been labeling them when we send the samples, that this is from the tibia, this is from the femur, so to say, and our microbiologist carefully preserves that. So we also get a feedback of how and where we have done extensive debridement, as to, just a feedback, because this particular patient had also symptoms of a tendinitis-like picture, which was developing over a period of a few months. And we always thought, and the previous surgeries were done in France. He was quite dissatisfied. Just to add, he was also running a lawsuit against the implant company who he was disappointed with. So there were quite a few things at stake. Knowing and doing a thorough tibial debridement there was of great importance. And actually, the bacterial load was highest in the tibial sample. Like Dr. Anisha mentioned, out of the 5 samples, 4 grew, and the best growth was again in the tibial sample. Fortunately, the best part of it was his symptoms of the patellar tendinitis have since disappeared. We thought it was strain on the extensor mechanism because of repeated surgeries, but actually it was the infection brewing there.
So I have a question to both you orthopedic surgeons. So is it possible for you to see the biofilm? Have you ever experienced seeing the biofilm on the...
Oh, yes. We call it the membrane. So when we take out the prosthesis, we run a relatively sharp instrument and scratch the medullary canal from within until we get very good bleeding from the medullary canal. Now, it's not a nice thing to see blood. It's rather sadistic here. But until I see a good bleeding bone, I don't stop chewing away at the bone. So especially in this case, I had to be a little more radical, pretty much like a radical tumor dissection is where I want extra and a little bit of live bone to come out from after I've taken the dead bone, because I don't have a second chance in this. So yes, to answer your question, we almost always see a thick fibrous tissue after the implant is extracted, even in aseptic cases. In infected cases, this has a little bit of fluid in it, some different color changes to it, and so on and so forth. But until that thick fibrous tissue is taken out, we don't rest. And that, in my interpretation, clinically, is the biofilm. I'll be also pleased to know what our other orthopedic colleague has.
Dr. Anand.
Doctor,
So
yes.
I'm not sure if what I'm taking out, you mentioned the fibrous membrane, and you also mentioned that we see it both in septic as well as aseptic.
Aseptic. There
so
is
I'm not
because
sure
of
what.
Yeah. Yes.
So I'm not sure if what membrane I'm taking is just a scar or fibrous tissue reaction, or it is actually the biofilm. I think the biofilm is like microscopic. We don't see with a naked eye. What we are seeing is fibrous reaction or reaction of fibrosis to whatever pathology is happening inside. And usually with aseptic revisions, you don't see a lot of fibrous reaction. With probably infections, the body is trying to contain these infections by throwing a fibrous reaction, maybe a pseudocapsule-like thing. That you see. But I'm not sure if that is the biofilm. I think biofilm is more, it is a glycocalyx membrane. It is more microscopic than visible to normal eye.
So one can culture those and find out whether we're growing anything.
Oh, indeed, we do.
Whether
We
we are
send
actually
that. We send that for culture. Yeah. The other question, if I may ask, is sonic this microbiologic, as in bug extraction from the prosthesis, very easily available in India? In India, I have never done that.
So we have set it up in my lab. We have set it up, so we are doing it.
Excellent.
And we have seen the yield is much better than the conventional.
Yeah. With our approach, we've now managed to isolate the organism in at least about 65 to 70% of cases. But in the others, I think this is something which we should take home from this. We should probably try and... Is it very expensive to set up, madam? Okay, great.
Not very.
Okay, great.
Here,
Superb.
I have a problem here. So my decision whether I'm going to do a one-stage revision or two-stage revision is done already. For example, it is not much influenced at the intraoperative findings. And sonication will give me the bug only after I have extracted the implant and then sent it to the lab for sonication where the organism will grow. It does not allow me to make an intraoperative decision whether I'm going to do a one-stage or two-stage. So I'm like, really, I don't know. For example, if I have made my mind that this is infection, I'm going to do a two-stage revision, and then I find a bug and continue to give IV antibiotics, that's different. But how does sonication help me to make a decision whether I'm going to do a one-stage or two-stage? That is my problem with sonication. It will give me a bug after I extracted the implant, but then I cannot leave the knee just like that. I have to either do a cement spacer or do a final definitive processes. I don't know how to answer this.
Pooja, if I could make 2 comments, please.
Yes, ma'am.
Yeah, thank you. So I wanted to make a comment on sampling, which Dr. Yogesh mentioned, and I think that was an excellent, kind of a brief that you gave on how you sample the specimens, and it would certainly help all our attendees, in getting better samples from patients with PJIs. So here, when you mentioned about putting all your fluid specimens into a blood culture bottle, my suggestion is always use a pediatric bottle. If you have even a large amount of sample, don't use an adult bottle, use a pediatric bottle and give us whatever additional sample in a sterile container, because that's very important to us. In fact, if you think of one organism, there is a possibility that doing microscopy, we'll think of 10 other organisms, and that allows us a little, free way to work around on different stains, and maybe, using different culture media or different blood culture bottles even at our end. So always please do spare some fluid for us in the sterile containers. And with regards to the biofilm production, the comment that was, meaning, or rather the question that was made. So biofilms are typically present on the prosthesis. One will not find it really on the tissues. but it's typically something which one would find on the prosthesis, and that's possibly the reason why if earlier cultures have not grown anything and you are extracting the implant, send the implant for sonication. And setting up, as Dr. Rupa said, setting up a sonicator in the lab is not something which is very difficult. These are very easily available. In fact, your CSSD would be using a sonicator already, only that they use a hot water cycle, whereas in microbiology lab, we can't use the hot water cycle. So you can easily disable it. They are very cheap equipments, just that, one has to be very, very careful when you use sonication as a process, because there's a large amount of fluid that gets handled, and the implant needs to be kind of put into it, and a lot of fluid. So contamination can be certainly one issue that the laboratory needs to be very wary of and ensure that things are done using all aseptic methods. So those are my comments. Thank you.
Especially for the second case presentation, I would like to thank all the experts and speakers, because they made my job easy. Whatever questions were posted from the audience in the chat box, majority have already been addressed. So thank you. And I would just request the experts to give in their one take-home message for the audience before I hand it over to Dr. Shaheen. The experts, one or two take-home messages or something new you all learned today or for our audience. Starting with you, Dr. Alankar.
It is multidisciplinary, and we definitely need help of other specialties like microbiologists and infection disease specialists, because they are not routine cases. They are very difficult to handle. And the implications for the patient are very expensive. And there is also very high mortality and morbidity. So periprosthetic infections are best avoided. But if we have landed up in a difficult situation, I think we need to take help from wherever it is available and follow scientific principles.
Sure, well taken. Dr. Vidyulata, your comments, take-home message, please.
You are on mute.
You're on mute.
Sorry. So yes, with regards to it's a multidisciplinary approach. So with regards to antibiotics, we will need a directed therapy, and with good bone penetration and a biofilm activity. So these three things go in to consider what antibiotic should be chosen, and source control will be it is of the topmost priority, and that is which will make things very different, because we've discussed gram-positive infections. We actually are facing very highly resistant gram-negative, where only colistin is sensitive and it has only 30% penetration into the bone. And we actually have nothing. And if it's Pseudomonas and Acinetobacter, even with Acinetobacter, your newer medications are allowed any which way. So, and whatever little newer drugs we have, that Ceftazidime, Avibactam, we are not very sure about that in Pseudomonas. So here, of course, again comes the infection control role and, stewardship policies. So here the cases were really, in that sense, easy to manage. But probably we left with the source control only when it is the resistant gram-negative organisms. So this is this would be my take-home message.
Thank you, Dr. Vidyulata. Dr. Rupa?
So, for me, I request the orthopedic surgeons to give more samples as it's expected, and a detailed history, because if you give a detailed history, then I can help better. So that is what is very, very important for us, so that we know how much time to keep the plates for, and look for the organisms that we are not picking up initially. So these are our earnest request to the clinicians. So we need a proper history and more samples. So that's it from our end. But it's interesting, both these cases, if you've seen, both of them are drug abusers. Both have been drug abusers, and both are 82-year-old, and they have done very well. I'm really thrilled about that.
Sure. Thank you, Dr. Rupa. So I would now hand over the platform to Dr. Shaheen for the further proceedings.
Thank you, Dr. Pooja. Wonderful academic feast indeed. I request all participants to please fill the feedback form to get your participant certificates. I thank the eminent experts, Dr. Vidyulata, Dr. Alankar, and Dr. Rupa. Also the enthusiastic case presenters and patient and interested participants also. And also BD in helping us putting together this session, this wonderful session. Remember that Bucktails is a recurrent program and the next session is in Jan 2023. The topic will be infective endocarditis. So anybody interested can please contact us on bucktails.scm@gmail.com. I repeat, bucktails.scm@gmail.com. A repeat reminder again to all MD microbiologists to please join Society of Clinical Microbiologists. For details, please visit scm.org.in. I repeat, scm.org.in. So the Society of Clinical Microbiologists is a professional platform for sharing knowledge and experience, addressing day-to-day diagnostic dilemmas, quenching the ever-growing academic thirst, promoting team building amongst clinical microbiologists, and educating the common public and contributing to the overall development in the field of clinical microbiology. Your participation will make this body stronger and help voice your concerns, issues, and discuss interesting case scenarios. Thank you all and have a nice weekend. Thank you.
Thank you, Dr. Alankar and Dr. Vidyulata. Rupa, thank you. Thank you so
I
much.
think,
for taking time out to join.
Shaheen, sorry to disturb you. I think Darshan probably would want to do a vote of thanks from BD. So probably let him finish that.
Okay.
No, ma'am, I'm good, ma'am. So on behalf of BD, I would like to thank everyone, ma'am, and Dr. Shaheen has covered everything. So, ma'am, all of you can switch on the camera so that we can have one group photo.
Darshan, this is most important, isn't it?
Yes, ma'am.
Evidence-based.
Yes. We missed Dr. Yogesh. Dr. Yogesh can please switch on his camera. If you can.
I'm so sorry, madam. My internet connection was lost here.
No problem. Another 15 seconds.
I'm actually in Bangalore. I had traveled for another conference. So I'm sorry, I couldn't.
No issues.
Yeah.
Thank you very much, madam.
Thank you, everyone.
Thank you so much.
Thank you,
to all of
Darshan, for always the support.
Thank you, ma'am. Thank you. Yeah.
Thank you. Thank you, everyone.
Thank you.
Thank you,
Thank
everyone.
you all. Have a great weekend.
Thank you.